Welcome to Oncology Radio. We are bringing you the latest information in the arena of oncology. Every episode brings you a new Maryland oncology hematology physician host, along with special guests in cancer research, new trials, cancer treatment, nonprofits, and cancer care. Maryland Oncology Hematology is broadcasting Oncology Radio from one of our 14 locations throughout Maryland. You can find Oncology Radio on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. So stay tuned and welcome to Oncology Radio.
Good evening and welcome to another episode of Oncology Radio. I have the good fortune of talking to Dr. Philip Imus, who is an assistant professor of oncology at the famous Johns Hopkins Hospital, where he specializes in myeloma. So thank you, Phil, for coming.
Good morning, Raveen. Great to be here.
So Phil, I was hoping if you could tell the audience a little bit about yourself in terms of where you grew up, what led you to oncology, and specifically what led you to specializing in multiple myeloma.
Sure. So I grew up in Maryland, outside the DC area. I went away for school to Houston at Rice. And in New York, I trained for 7 years at Columbia before doing my fellowship at Johns Hopkins, where, among other people, Raveen, you were one of my teachers in the outpatient clinic. So I've learned a lot from you. Joined the faculty in 2017, specializing, as you say, in myeloma. I think what I love most about myeloma is how well I get to know my patients. Sometimes it's not a great thing to know an oncologist well, but myeloma for many people is a manageable disease, and so just getting to know people is one of the best things about what I do.
I think you do a wonderful job, Phil. I always remember, even at an early age of your training, how kind and very smart you are. So they're grateful to have you in the community of multiple myeloma. So Phil, I want to kind of delve into the treatments. In terms of myeloma, there's all these different options, right now. And, for fit patients, we oftentimes will give lenalidomide, bortezomib, and Decadron. And I'm hearing more data, including this Griffin study where they're giving daratumumab in conjunction with frontline RVD. And I was just hoping if, from your own perspective, how do you approach patients for initial therapy for myeloma where we want to be aggressive in their care?
It's a really open question. We talk about it a lot at our faculty meetings. The Griffin data are, they make you feel good. Patients with newly diagnosed myeloma are doing really well. Most of them are getting a response. Some of them are getting really nice, deep responses. And so that's really heartening about the Griffin study, which looked at the addition of daratumumab to what I think a lot of us, a few years ago would have considered standard Revlimid, Velcade, and dexamethasone. It's getting harder and harder to prove that oncology drugs improve survival in myeloma. That's obviously what we're interested in the most. But daratumumab is such a well-tolerated drug that it's hard to imagine that the combination of the four isn't better than just Revlimid, Velcade, and dexamethasone.
And Phil, as a great point you bring up, one thing that patients will ask me a lot is, we have all these great drugs for myeloma, but is there a disadvantage, you think, where we front load all of our options, whereby we may not be able to offer those drugs in later lines if, God forbid, the cancer were to recur or relapse?
Well, certainly that's a concern, but I think the flip side of that is we don't know. We often use the same drugs in relapse as we do in first line therapy. I have many patients whom I've treated several times with Velcade or with something like Revlimid, and we still see efficacy. So that's not really a concern. We're fortunate to have other options even beyond the DARA RVD type regimens. So it's certainly something to think about, but I don't think it outweighs some of these potential benefits.
Well, Phil, and I think your point's well taken. So, Phil, when you approach a patient with multiple myeloma, now again, maybe a younger patient who's healthy, where we want to maintain an air of aggressiveness with their care. So, is there certain cohorts where you may consider giving daratumumab versus just the standard RVD? And what would those prognostic or predictive tools, what do you use to kind of tailor your therapy for frontline treatment?
Raveen, you bring up a great larger issue, which is how we think about prognosis and how we predict response to therapies in multiple myeloma. So, there are certain tests that I try to talk about with all of my patients. One is the FISH or the karyotype or the chromosomal changes of their myeloma. There are 5 or 6 changes that we see routinely in patients with multiple myeloma, and some of them are associated with certain things. So, for example, translocation 1114 is a movement of genetic material between those 2 chromosomes, and if your myeloma has that, we think that you have a standard or a good risk prognosis. There are some translocations that are worse, or chromosome changes like deletion 17p. But there are problems when you get to myeloma. So first, it's a disease where outcomes are really variable. I have patients with very, very, very aggressive myeloma, and I have other patients who, it's mostly manageable over years and years. The genetics of the myeloma help predict that, but it's not the same thing as telling the future. So, if a patient has a certain genetic change, I can tell them what many patients with that change experience, but not what they will. Similarly, we don't have ways to predict or choose therapy, at least initially, in patients with multiple myeloma. So, we do separate patients into how we think of them as eligible for transplant. We may talk about transplant later on. And that just has to do with, how well they are, how active they are. Some older patients who are, not as active as they would want to be, sometimes we wouldn't think of for aggressive therapy, but otherwise, I tend to recommend the same type of therapy for all of the fit patients.
And so, is there something, Phil, where you give daratumumab frontline currently right now, based off the phase 2 Griffin study data set, or are you holding off until you get more mature data?
We at Johns Hopkins are starting to offer daratumumab in addition to Revlimid, Velcade, and dexamethasone. We think that Griffin data is pretty compelling. There are other studies that are coming out, but one of the things that is most impressive about the Griffin data is the level of MRD negativity. In patients who have done well with frontline therapy, that may play into the decision about whether or not they would benefit from a stem cell transplant. So, in that sense, we think that getting deeper remissions that are clearly apparent with the Griffin data is probably worth the addition of daratumumab.
Well, and I think that's a wonderful point, and it's really great to see the data with MRD and how we can use it as a tool to tailor our therapies. So speaking of autologous transplant, so in a community setting, I think that treatment, paradigm really brings up a lot of great discussion with patients, because, they'll ask us, what's the gain of doing an auto transplant? And so, we'll talk about this data set, IFM 2009, and we'll talk about progression-free survival benefit. But patients will oftentimes ask, can it lead to a cure, and why not? And so I just wanted to get your macroscopic sense of, how does autologous transplant play a role in your care for your patients, and what benefit do you think that we're driving, from it for patients?
Yeah, so I agree. This question of stem cell transplant, I certainly see sort of the widest range of patient opinions about, and it is always great to talk about. Autologous stem cell transplant has been around for 40 or 50 years. It's an old technology. The idea is to give a very high dose of old-fashioned chemotherapy. Most centers use a drug called melphalan, And the dose is so high that if you didn't do anything else, it would get rid of your bone marrow and you wouldn't be able to recover. So the stem cell transplant portion is where stem cells are taken from your blood ahead of the procedure and then stored and then given back later. So they're protected from the effects of this melphalan. Drugs are getting better. More and more FDA-approved options are showing promise, and so a lot of us have asked whether we still need to do this. And the IFM data that you mentioned tried to answer this question. So, very briefly, it was a study that took 700 patients, and it assigned them randomly to one of two groups. To either get a stem cell transplant early on, immediately after they finish their induction chemotherapy, or to delay it until the first relapse. So all 700 patients got Revlimid, Velcade, and dexamethasone, which, as I said, is considered a standard of care. One group got an early transplant, the other group did not, and both groups got Revlimid maintenance, which is an important part of upfront therapy, is maintenance therapy. So, they've looked 8 years later now, and the two groups did not have any difference in overall survival. And to answer your point, Raveen, which is another great question, we don't believe that any of these patients are cured. Remissions are longer in the group who got a transplant. So, the group who got a transplant stayed in remission on average a year longer than the group who didn't. So the 30,000-foot view would be that, autologous transplant works to prevent relapse of multiple myeloma, but it doesn't cure anybody. And there are real side effects associated with it. And so, it's not for everybody, but I do encourage everybody to hear about it and to talk about the benefits and the drawbacks. I think other people will mention or tell you, and it's absolutely true, that the IFM data did not randomize patients to getting a transplant or not. That's not a question that's been answered. It randomized them to a transplant up front or a transplant later. After the disease came back, patients would get more chemotherapy, get into a second remission, and then go to transplant at that point. So, we see this in oncology studies all the time, but if both groups get a certain treatment at a different time, there's this potential for what we call crossover, and all that means is it may erase some benefit in survival that we would see if the patients didn't get a transplant. So there's a lot of there are a lot of unknowns, but what's not unknown is the process itself, and most patients do tolerate it pretty well. So it ends up being a discussion between a physician and a patient.
Because there's some wonderful points, Phil. And Phil, one question that comes up a lot, with patients also in the community is they'll read online that an allogeneic transplant, where we use cells from a matched donor, whether it's related or unrelated, would that be more effective potentially because you don't have quote unquote potentially contaminated cells of your own that you're reinfusing into the patient? If we use someone else's cells, perhaps we can have more of a graft versus myeloma effect, albeit with a lot more toxicity. So I was wondering if allotransplant, what are your thoughts in terms of its place in myeloma, if at all, and when would you consider deploying it for a patient?
Yeah, it's Raveen, it's a great question. Allogeneic transplants are used routinely in many blood cancers. So, acute myeloid leukemia, acute lymphoblastic leukemia, many aggressive lymphomas, myelodysplastic syndrome. So, we at Johns Hopkins do a lot of allogeneic transplants. And what we've been able to show is that the safety of this procedure gets better and better every year. So, modern allogeneic transplants are associated with 5% risk of dying. So they're incredibly safe. And this has been really a remarkable improvement since, even 20, 30 years ago when mortality was as high as 40%. So that's allogeneic transplant in general. It has a difficult history in multiple myeloma in that more than the other diseases that I mentioned, even if an allogeneic transplant is performed very safely, myeloma has a much higher risk of coming back. So, about 2/3 to 3/4 of the time, the myeloma will relapse. We often say that that's better than autologous transplant, where 100% of patients relapse. But even with a safe procedure, we don't routinely offer allogeneic transplant to patients with multiple myeloma. The discussion is almost always for an autologous, or where you use your own stem cells. There are patients in whom we sometimes will offer an allogeneic transplant. It's usually done in the context of a clinical trial, looking at different methods of maintaining a remission, something of that nature. But in patients who say their myeloma is very unresponsive to multiple lines of chemotherapy, these are patients who, we say, look, obviously standard therapy is not serving you, and we should think about this sort of more aggressive therapy.
Well, that's a great discussion and a great point. And Phil, speaking of maintenance therapy, I believe in the IFM 2009, they used about 1 year of lenalidomide. I know many thought leaders in the field advocate for indefinite lenalidomide for maintenance, let's say after an autologous transplant. I was wondering if you could speak to what your practice pattern is for that. That I've heard reports of perhaps it contributing to secondary malignancies, which can provide pause for patients. And lastly, for patients who are very high-risk myeloma, let's say deletion 17p, do you incorporate a proteasome inhibitor in concert with the Revlimid as maintenance therapy?
Maintenance is, one of the most important parts of initial myeloma therapy. It kind of doesn't matter what drug you use. Maintenance therapy has been shown to keep the myeloma away longer. It may even make patients with myeloma live longer. There are several problems with it, which maybe we'll get into, but in general, it's an important part. And my patients, feel well. What I tell them is, early on in the disease, you may be feeling sick from the myeloma itself, and then you start, these 3 new drugs, and everybody has side effects. So we don't expect you to feel great. We try to help to make you feel great when you're first diagnosed, but the goal there really is to decrease the amount of myeloma in the body as quickly as possible. In maintenance, the idea is very different, right? I mean, if you went through that and now you're in remission, it's really time to enjoy the fruits of that labor. And so I think patients should feel really well while they're on maintenance therapy. And so, I'm very careful. So you mentioned lenalidomide. So, a common starting maintenance dose is 10 or 15 milligrams. And, I say, look, let's start this and see how you feel. And if patients have, symptoms or side effects that are interfering with, how much energy they have, or, what they're able to do, then, we come up with a plan to fix that. And that often involves reducing a dose. You talk about the length or the duration of maintenance therapy. There have been studies that look at 1 or 2 years of lenalidomide maintenance. There are studies that look at using it indefinitely. It's not clear that one is better or worse than the other. But you're right. The practice pattern in general in the United States is to give patients or offer patients lenalidomide maintenance as long as they're in remission. In European countries and in other places, the standard tends to be of limited duration. In practice, what I often do is after a patient has, achieved the 2-year mark of maintenance, and we've already talked about the duration usually beforehand, but what we say is, look, you've been doing this for 2 years. Nobody knows whether 2 years or indefinite is better. How do you feel about it? How are you feeling on it? What's the financial toxicity to you? Are you having side effects? And we have a discussion. I will say that, probably 80 to 90% of my patients that I have that discussion with will continue, but some don't. And I think they're both doing well.
Would you ever consider giving the Velcade with the Revlimid? Let's say if you had a 17p deletion fill and you really wanted to optimize the maintenance therapy for that patient who might have a quote unquote worse prognosis?
Yeah. So, Velcade is a good point. One of the things that I make sure to talk about with all my patients. So Revlimid is the drug that's been the best studied. I would say the most is known about Revlimid maintenance therapy. And what's known is that about 2 or 3% of people will have a second cancer that's attributable to the Revlimid. It can be any cancer. Things like leukemia may be overrepresented. It's rare enough that the whole group still benefits, but it is a real side effect. And I think a very real reaction to that is, well, I already am dealing with one cancer. I really don't want to face another. If for that or other reasons, I do have many patients who are on Velcade maintenance. I don't tend to combine the two. There have been studies that looked at all sorts of different paradigms after autologous transplant. And, in an individual patient, there may be a reason to do one or the other. But, I would say for most patients, just either lenalidomide or Velcade maintenance is all we know that can help. You mentioned the high-risk patients, and yes, they are at a higher risk of relapse. They tend to relapse sooner after auto transplant. But we don't know enough to do anything differently. There are studies looking at daratumumab in maintenance, and we haven't started to incorporate that, but it is something that I know that some are starting to do, and I don't think it's unreasonable.
And Philip, I have two more topics I was hoping to talk about if I could, and thank you for that discussion. So for relapsed myeloma, as you'd mentioned, we have a panoply of different options we can offer. And one thing that I think has captivated the imagination of scientists, clinicians like yourself, along with the lay public, is CAR T cell therapy, where we reprogram the T cell lymphocytes to target myeloma cells, specifically BCMA on the surface of the myeloma cells. And I understand adacaptogene was recently approved, a CAR T cell for multiple myeloma. So I was hoping if you can talk about that data. Have you used that drug yet? What are your thoughts about CAR T cell therapy going forward for patients with myeloma?
So Raveen, it's a great question. I think, for history's sake, we should note that we're talking in July of 2021. The reason I say that is because, CAR T cells are changing so fast. In some of the blood cancers we mentioned, although not all, CAR T cells have really changed the game. There's a portion of patients who are cured by CAR T cell therapy. They are also dangerous. About 5 to 10% of people will die from complications, but it's really changed the game for a lot of patients who didn't have a lot of other options. The story in myeloma is actually very similar to that of allogeneic transplant, in that nobody is cured, or we don't think that anybody is cured by the current CAR T cells that are available. They are getting different or better, perhaps. They are studying ways to prevent this type of relapse, maybe making them stick around longer. We don't really understand, I don't think. So hopefully this will be a technology that will get better. And, I could foresee 50 years from now that everybody gets something like this. But in July of 2021, the data are that they can achieve remissions in some patients with, relapsed multiple myeloma. I think there are a lot of practical limitations right now. One is just the availability. There aren't enough abilities to make these CAR T cells right now for all the patients who need them. The other is some patients, their immune systems won't allow them to make CAR T cells. They're based on your own lymphocytes, and at least at present, although once again, people are working on ways to get around this. But if you don't have lymphocytes available for harvest, then you won't be able to manufacture CAR T cells. So there are a lot of promise. There's a lot of problems. I mean, these are the very early days of CAR T. So I think that things will change a lot in the coming years.
So thank you. And Phil, one last question. So, we've referred a lot of patients to you, given your wonderful expertise and wonderful person also, and you're doing a lot of clinical studies. So for patients who may be looking to come to Johns Hopkins for clinical studies for myeloma, I was wondering if you could talk to us about one or two clinical studies that you're most excited about at Johns Hopkins that you're conducting currently.
Sure. Thanks, Raveen. I think so. There are several studies that are open or are opening. I think, and maybe listeners or Raveen, I'm sure you talk to your patients about this too. But I think just the importance of clinical research in general. The first thing is that one should always consider participating in a clinical trial. There are some trials that are looking at studying patients who don't yet have myeloma, who maybe are at risk for having myeloma. And the more that we learn about these things, the more we can tell patients and the more that we can offer them. So, there are studies looking at early therapy of multiple myeloma. The Griffin study that you mentioned, those were all clinical trial patients, and they got, completely novel therapy. We have many FDA approved options for multiple myeloma right now. There have been FDA approved drugs in the last couple of years that show efficacy in patients who have relapsed after a lot of good drugs. And they have a lot of toxicities, which is, not surprising. I would love to see more drugs available that are effective, but also don't have a lot of toxicity. For a lot of patients, they want to feel well. They don't want to feel like they're sick all the time. And so, looking at ways to get drugs like that approved, I think are really exciting. We have trials available for patients who are on maintenance. We have trials available for patients who have relapsed after some of the, what I call the home runs, or the drugs that, work a lot and are pretty well tolerated. Things like daratumumab and carfilzomib and lenalidomide and pomalidomide, bortezomib. These are drugs that are really well tolerated and that every patient should talk about. But there are patients who would benefit from something new. And the other thing I always talk about with patients, if they're having a hard time deciding whether they should think about a standard of care drug or a clinical trial, I tell them all this is that it's not wrong to go with a standard of care, certainly, but that standard of care will be there if this trial doesn't work. There are some options, or there are some instances where you want a sure thing, but there aren't any sure things anymore for some patients, and so these are good opportunities to try something new and know that there's still options available.
Phil, that sounds wonderful, and thank you. And I wanted to thank the audience for listening to this podcast for Oncology Radio, and I'd like to thank Dr. Imus for attending. Thank you, Phil.
Hey, thanks, Raveen. It's great to talk to you.
Great to talk to you too.
Bye.
Thanks for listening to our latest episode of Oncology Radio. You can find the broadcast on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. You can find more information about our physician hosts from Maryland Oncology Hematology at www.marylandoncology.com. Subscribe to our show on Spreaker at www.spreaker.com/user/Oncology Radio. And remember to follow the guidelines and get your cancer screenings for the best defense against cancer.